Hi, everybody. Good morning, good afternoon. Welcome to the latest in our seminar series around the Your DNA, Your Say project. So for those people who haven't met me, I'm Richard Milne. I lead research and dialogue activities within the engagement and society team at Wellcome Connecting Science. And for the last couple of years, I've spent a lot of time working on Your DNA, Your Say, which is our global survey around attitudes towards genomics and data sharing. And it's an enormous, it's really exciting. It's a real privilege this morning to be joined by our Indian collaborators, Krataline and Hasan and Sahoo, to present the analysis of the data from India and to tell us more about the Indian context. So Annie is president of the Board of Genetic Counselling of India and senior consultant and research director at Kamineni Hospital in Hyderabad. And I'm really looking forward to hearing what they have to say. If you have questions during the seminar, then please do drop them in the Q&A as well. And then we're hoping to have time to talk through questions afterwards. So Annie and Swam, I will hand over to you.
Thank you, Richard. Let me at the outset say that how fortunate I feel that I'm part of this Your DNA, Your Say survey and the whole group, because it's got me connected to everybody all over the world globally. So apart from the publications and all, it is the interaction and the human interaction which has really made me benefit a lot. And I hope Swam also joins and feels the same about it. So today we are going to discuss role of awareness in DNA data sharing and public opinion, challenges what we have observed. We want to see how important is awareness for exercising trust and sharing DNA data. I'll be presenting the beginning of the talk, and Swam will take us through other focused discussions. For those of the people who haven't been with us and they are new to this talk, I'll just give 2 slides about what Your DNA, Your Say is. This is a global online survey which gathers public attitudes towards genomic data sharing. The survey is gathered in 15 languages, and these languages will increase. And we have the survey conducted from 22 different countries. The sample had 36,263 participants, and 3 publications with different aspects of this have already been published. And there have been other data from different countries like the German data and all, which had their separate publications. India, both Swam and I with Richard's, but we are still in the process. So what we have learned up till now is the global public perception of genomic data sharing and what makes a person willing to donate DNA. In the second paper, we talked about trustworthiness and sharing of genomic data. And in the third paper, it was about return of genomic result, donate their data. So in the previous studies for Your DNA, Your Say, the Indian perspective was the Indian data of the 482 responses. And what was most striking and what was discussed even before the publication was that why is it that different from rest of the world, Indian people are willing to donate data for profit research. Now, this was something we discussed, and we thought that is it because the Indians trust private healthcare system compared to the public one? And I'll give you some background of why this happens. We also found that there's a weak association between trust and willingness to donate DNA and medical information. And Indian data showed the lowest range, that is 5%. The endorsement was for details about sanctions for misuse of data. And returning the results was the major force which influenced 28% of the people. Now, I've just taken a clip from one of the publications, and in this you can see that Indian data comes in the middle of United States and Japan, where it says they are not willing to donate. So India comes somewhere in between there, then they are unsure, wholly unsure, and so on. And this also is a part of the figure which has already been published, that willingness to donate DNA data, it is majorly influenced by information about who will benefit and a website explaining the pros and cons of data access. And the things which least concern Indians are details about sanctions for data misuse and direct communication with data gatekeepers. Now, to understand these, I wanted to bring in some relevant facts about the India's health economics. India is slated to be the world's most populous country by 2025 and the third largest economy in the world by 2030. India's health system performance has varied widely over time periods, states, and indicators. Because in India, health is a state subject. Although the central government makes certain policies, it's the states which put in a particular budget for implementing health strategies. Some of the key aspects of health system performance in India clearly lag behind both global and regional comparators, like if we compare to Bangladesh, Sri Lanka, Nepal, and Pakistan. A government service delivery system which has traditionally focused on reproductive health and infectious diseases while neglecting non-communicable diseases, which now currently are the dominant share of the disease burden. Another very important thing about India is that fragmentation and lack of coordination between different levels and sectors, even within the private sector, which is the dominant service provider for Indian health services. So if you see the health sector, there is a lack of accountability in the service delivery model. The focus has always been on infrastructure and not on outcomes and accountability. The underperformance of government health facilities and the emergence of a large private sector as patients started taking care elsewhere. So at present, 70% of our outpatient utilization and 58% of our inpatient utilization occurs in the private sector. If you see the table, there is urban rich and urban poor. If you see at the bottom of that, you will see that urban rich go to private doctors and private hospitals, 76%. But the urban poor also, it comes to 37%. So you see if you go to the last column there, at the right side, you will see that more than 50% of our population, irrespective of urban, rural, has their healthcare needs met in the private sector. This is a graph which shows the public-private healthcare in every state. The dark blue are the public and the light blue are the private. And you will see that you see the public sector things very high only in the Northeast region, because that is the region which, as of now, India is focusing on for getting the healthcare services up and running. But I'm sure once that is stabilized, the private sector will take over. Now, coming back to the study of our data, you see the methodology has been, we are going to discuss it under phase 1, phase 2, and phase 3. In phase 1, there's phase A and B. A is what I have already discussed and which is already published. It was based on the market research company which recruited individuals, and the participants completed the questionnaire on tablets provided by field researchers. But today what we are going to talk about are the 1,050 responses, which include this. And the recruitment was by voluntary participation and snowballing. Phase 2 was focus group discussion, where we did it on educated and aware and educated and unaware. Educated and aware includes genetic counselors, students of life sciences with genetics as one of the options, healthcare practitioners involved with different genetic aspects of disease. And educated unaware include teachers. Phase 3 will be qualitative data and its analysis. So if you see the demography of participants in phase 1B, males were 60%, females 40%. And if you see it in different age groups, there was not much of a difference. It was only in 21 to 40 where you saw that there were more males. If you see education qualifications, the right side bars show you the individuals who had no formal education, and these were the people who required a survey to be filled by one of our counselors because they did not have access to understanding any written form. They were not used to reading and writing, but they could, when you read out the question or translated the question, they were able to give us the answers. Now, otherwise, if you see, there was not much of a difference in the education qualifications. Secondary education, a bit higher percentage of males. You have to realize that this online survey was completed by individuals who are familiar with Urdu and English, and that is why they are not a true representative of all the states in India, because as you know, India has 22 state languages. So now the study pushes for the idea that how factors like age, gender, educational qualifications, and a little bit about religion, which affect societal willingness to donate their DNA data. So willingness to donate overall was 28%, and we wanted to see whether it was influenced by how many people wanted to donate it conditionally to get information of readout or result. So what we found is general donation for good was more in females, with 39% willing to donate without even knowing what exactly it is. But males were more when there was a conditional donation. Now, funnily, they were not influenced by whether we returned their reports or readouts. And we are not sure what they were looking for. What was the condition which they wanted to base their donation on? And we are speculating, is it a remuneration they were thinking of? But that has not been a subject of this survey, so we are not going to touch upon that. One thing which came to our mind when we saw the percentage of people who self-indicated that they were religious, 92% of our population, 92% of our male population said that they were religious, and 89% of females said they were religious. But if you see the willingness to donate, if we believe that religious people are more giving, we did not see that at all. We found that people who were not religious were similarly willing to donate. In fact, the percentage of females who were not religious willing to donate was much higher than women who were religious. So this is something of an eye-opener for us to use in our future discussions. Now, when we see the age, we see less females of older age willing to donate, but in the younger age group up to 40, males and females have no difference, but it's after 40 that we find that more males are willing to donate than females. Now, willingness to donate based on education. This is a very striking chart which shows you the first two bars where there's no formal education and primary education. We see a difference in gender, but subsequently with secondary, current education and university education, this. So we believe that education is an equalizer, with both 80% males and females willing to donate when they have had a university education. So now, familiarity with DNA. So overall, we can say in conclusion from all this data that familiarity with DNA increases with increasing educational qualification. Men are more familiar when compared to women, because the simple fact is that more men are educated than women in India. Willingness to donate increases if the participants are told about a regulatory law to safeguard this. Swam will be dealing with this in more detail. She will be telling you about exactly the percentages and odds ratios. There's a weak negative correlation between age and privacy. And we felt that elderly people that who are above 65 or so, they were not so much bothered about privacy. So by and large, we felt that the ones who wanted to donate were doing it out of an altruistic thing, that it would be for a greater good of society. But the ones who were not willing to donate are a different issue. So now, during the data collection phase, the major problem which we came across was that were they aware of DNA? And this made it difficult for them to channelize trusting to give something. If they don't comprehend the existence of something, how do they comprehend the relevance of donating it? So that is why we went on to do focus group discussions with educated individuals, because our study up till now showed that education is an equalizer and educated people are more aware. So should we go on? So then we decided that we would make this focus group discussion into educated individuals who are familiar with genetics and not familiar with genetics. So we did a smaller survey with 100 responses, and it was given to genetic counselors, students with genetics as a specialty, and healthcare providers. And what did we find is that in this cohort, there were more females, because I think world over, there are more female genetic counselor than male. So we had 70% female, 76% females, and 24% males. Age group, again, 18 to 30 was maximum, because we had taken students and genetic counselors, and genetic counseling is a young profession in India, started only in 2007. So that's why I think we got the largest group in the 18 to 30, and then 31 to 50, and more than 50 was the smallest, which I think in counseling and the academic programs. Now, we were really surprised to see that 3.6% of these people also said they were not familiar with DNA, but with those healthcare providers who were dealing with genetic disorders, like ophthalmologists, physiotherapists, and all, who knew genetic disorders, but did not really know about DNA and genome. Now, from this group, 57.3% were willing to donate. So now, it's a major chunk. We initially saw 28% were willing to donate, but from this group, who was aware and knew about DNA, 57.3% were willing to. And in this group, the major reason and major motivation for donation would be that DNA or medical information, access to the data, and who the data is being used by. And most of the people appear to be comfortable sharing the DNA data with a doctor and a non-profit researcher. So there it comes. From what we saw earlier to now, when people became aware about DNA and the genome industry, they did not show a willingness to donate to profit. Now I'll hand over the presentation to Swam and she will take it forward from here.
Hello, everyone. I'm Swam Siddha. First of all, I'd like to thank Annie ma'am for giving the study an amazing start. And thank you, all of you at Cambridge and the listeners for giving us a chance to tell us about our research. So, as ma'am was talking about familiarity, and I went on to the field to administer the survey, the ydys survey, the predominant questions that were asked to me by the people was, what is DNA? Where is it? Does everyone have it? I will only donate my DNA if one of my family member requires it. How is it even possible to donate my DNA? I don't even know where my DNA is. And I also had questions like, how do I have access to my own DNA? So when such questions came at hand to me, it was a greater problem to, first make people understand what I am talking about and what this survey intends to do, and then administer the survey further, which raised an important question, a very pertinent one rather, that how important awareness is before we put in the question of where do people put in their trust to donate their DNA data. Awareness and trust go hand in hand. For example, if I do not know that what I possess is of what value, then I don't know who I can be trusting it with. Which third party can I bestow my trust upon? People need to be aware that what they are possessing and what value it is to the state, the market, the people, the research, etc., before questioning them about where they bestow their trust. The Indian data mostly showed that people do not relate to the idea of DNA because the ydys survey had videos of small snippets explaining what DNA is and how you can trust it on different people, all the third parties, the problems with it, etc. But people were, because they were not able to relate to what DNA is, the translation of knowledge was not easy. And that is why, even if I ask them a hypothetical question that, if ever you were to donate your DNA data, they were not able to relate. They mostly thought of DNA as an organ that can be donated, and they will only be willing to donate it if and only if a family member wants it. The sample had to be explained what DNA is, how DNA donation works before any survey could be administered, before the ydys survey or even the FGDs. FGDs mostly for the educated and unaware group. This occurrence was a testimony of the information asymmetry that India has, lack of awareness in people, and some group of people that have the privilege to know certain things and some who do not. So what does ydys data for India say? This data that I will be discussing will be about the 1,050 participants that were collected through the major ydys survey. The odds of being unfamiliar with DNA is increasing with age. Like the age group 41 to 60 are more than like twice as unfamiliar with DNA, and 61 plus would be almost 4 times unfamiliar. The odds of Indian women being unfamiliar was higher compared to Indian men, mostly because Indian women seem to drop out of schools very early, mostly in the secondary, and very less make it to the tertiary universities and all. And whereas Indian men have the privilege to go on to study, and hence they are more aware and more familiar with DNA and genomics. Indian population who have completed or are pursuing studies in tertiary educational institutions were at higher odds of being familiar with DNA compared to others who were pursuing secondary schools, and to people who were who have just completed their primary education or were not educated at all. So the major question was, if people who were aware about DNA, do they see DNA and medical data differently? Again, older people were less likely to see DNA data different to medical data. And people who have completed or were pursuing education in tertiary institutions were more likely to see DNA different to medical data compared to the other cohorts, like the secondary people who have completed or pursuing the secondary education, or people who have just completed the primary education. The odd ratios also show the same thing, that tertiary education almost were 3 times more aware of DNA being different to medical data. However, this had no impact on the gender aspect. So we administered the question that if people would be more comfortable sharing their DNA, if there was a regulatory law in place that protected their privacy. Older people here were less likely to be reassured by a law in place. Literature suggested that this might be because of the indifference, because they were unfamiliar with what DNA was and the specifics of it. They did not really care that even if a law will be at place, if they will be interested or be comfortable sharing their DNA data. That is why the odds ratio for 61 plus cohort was at 0.19 compared to 0.66 for 41 to 60 cohort. Women were less likely to be comfortable sharing their DNA data, even with a law in place. This was also recapitulated with the negative experiences that women have in the online arena, which makes them skeptical about sharing their data, that whatever data that concerns their privacy. So that is why they were more skeptical. The odds ratio for female was at 0.7 at 95% confidence interval. Educated people are more likely to be reassured by a law because they are more, they know how the law works and they have access to the law and how the law institutions work. That is why the odds ratio for people who have completed the tertiary education was almost at 2.5, and that of the secondary was at 1.29. What more? So one thing that we have to take with a pinch of salt is the willingness to donate their data. So when Annie ma'am was discussing the willingness to donate the data, 95% of the data said that people claim that they have no data online. Hence, there is no question of them to be willing to donate their data. So that is why most of the questions were not applicable to them. And they said that the question is not applicable. However, Indian healthcare systems uses computer networks, cloud storage, or even raw maintenance of data files to save patients' data. Even if people are unaware or just merely ignorant that they think that their data is not online or cannot be procured online, does not mean that DNA or data cannot be extracted. As people are unaware about what DNA is and where it is found, feeds into the thought of denial about having their DNA data online. Younger, educated males are the ones who are most aware about DNA and the data compared to the old uneducated females. For old uneducated females, they are the most vulnerable group, and there are a lot of intersectionalities at play for which they become the vulnerable group and they do not know how the entire system works. Younger educated males will be the ones who would make the policies at the center to safeguard and regulate the use of DNA data. And that is what is the major concern, because all the groups which are vulnerable or do not have a say in making of the policy raises more concerns about how the policy would be and who the policy would cater to. In our first focus group discussion, which we had with the educated and aware group, which contained the DNA genetic specialists, practitioners, and students, the total sample was 100, and for the FGD, we selected a sample of 20. Here we found out strikingly that the younger cohort was very skeptical about sharing their DNA data than the older cohort, because the older cohort mostly was indifferent. It was simulated by the effects of the Indian political scenario. Here I would like to tell you briefly about the Aadhaar thing that happened in India. So Aadhaar is a unique identity that every Indian has. And it collects your biometrics and it is stored in a central system and it can be acquired by wherever you're applying through your Aadhaar. That has given rise to people being wary that the state is having a surveillance on them and can breach their privacy as and when required. And it has also been seen that state is selectively using data from Aadhaar to have different policies for different people or treat different people differently. Both old and young cohort shared concerns over sharing DNA with the market because of its capitalistic pursuit. The DNA, the old and young population said that if they give their data to the market, they never know how the market uses it for its own gains. And hence, because it feeds into the capitalistic system and you never know how your data is collected, how it is used, how it is stored, who has access to it. Hence, they had much concerns over sharing it with the market or businesses. Both of the cohorts agreed on donating their data for the betterment of the society or for research, mostly non-profit research, because that would give rise to things that would require solution, like genetic diseases and concerns like that. That would be better for the society, and it would give rise to better research in genomics. And hence, this is the altruistic pursuit that we found out in the focus group discussion, first focus group discussion. And all of them said that if there is a proper law in place that regulates the intervention of the market, state, and society on DNA data and how it is being used, it would mitigate most of their concerns. So after focus group discussion, the second focus group discussion was done with educated and the unaware group. It was mostly primary and secondary teachers at district schools, and the number was 15. They could not relate to the idea of DNA at all. All the quotations that I shared before beginning the presentation were from this focus group discussion, and they could not comprehend, like they thought it is kind of a jewelry or kind of an organ that they can give to some, they can see it in hand, touch it, and then give it to someone else, or someone can steal it from them. Women were more skeptical, obviously because of their privacy concerns in sharing their DNA, but were very much interested that if a family requires it, they will happily give it. All teachers agreed that they would donate their data only and only if the family requires it. It shows that they are mostly, they put their trust on the family and their requirements, and do not further their agenda towards the state or the market, etc. It is only because they were not aware about how DNA works, how DNA data is collected, etc. So as we went through the entire discussion, the major thing is our world is going into a situation where there is a coupling between DNA data and the big data. Both are sunrise industries, and the market for DNA testing is currently growing in leaps and bounds. It holds a lot of possibilities. We can mitigate potential health hazards, genetic predispositions to different traits and conditions, and it can answer a lot of questions that is a pursuit of genetics. We can give rise to an all-knowing medical health service and provide service at places where it is difficult to reach. It will ease fighting epidemics, shield us from diseases like cancer, heart diseases, diabetes, Alzheimer's, etc. But coupling of DNA and big data also puts us in the major question that if people here are not aware at all about what DNA is and how it works, they are not able to relate to the basic idea of it, and knowingly or unknowingly they are becoming a part of the huge global network, will they be able to remain autonomous, or it's just like without knowing they are a part of this entire system? And is our society and polity prepared for this discourse? Again, as we saw that people are more willing to share it with with the society, for betterment of the society, for non-profit research, but they always are skeptical when it comes to market, because they relate market with mostly its capitalistic pursuits. Both quantitative and qualitative studies in India showed that Indian population is quite very wary of sharing their DNA data with the market. Given the recent court cases with Google or Facebook, they know that the privacy concerns are important, and these markets are breaching our privacy now and then without us even knowing it. They believe that the inherent capitalistic tendencies of the market make them corrupt. You never know how your data is being collected, who has access to it, how and where your data is being sold without even you knowing it. Concerns over how markets access individuals' DNA information, how it uses it, and how it capitalizes it were very big, and hence they were not interested to share it with the market. For example, 23andMe is a private company, which here 23 stands for the 23 pairs of genes, that chromosomes that we have. So 23andMe can collect your DNA data and sequence it for you and tell it if in future you can have any disease or so. But the concerns raised were, if you collect all the data, given the person will get their DNA sequenced and will know what future holds for them, but they never know how the data can be further used by 23andMe and how it will capitalize on it. So here I would lay down some grounds for effective regulatory public policy. Mostly when I discussed it with all the sample and all the people, they wanted a bottom-up approach to understand so that the people at the center making the public policy should understand the ground level problems. Young educated males mostly design the policies in India, and that widens the intersectional gaps. And hence there should be a mix of people who are genetic specialists and people who are laymen, so they can come together and understand the issues at hand. The agenda setting of the policy should be founded on the premises of how aware Indian population is towards DNA and DNA data sharing, rather than any other concern. The envisaged policy should regulate how data is being collected, used, and protected or stored. I want to end this dialogue by putting forth a question to all of my listeners. The coupling of biotech and infotech are now a global phenomenon, but should the policy that we envisage be global or local? And with this, I want Annie ma'am to summarize the discussion.
So after this brief summary, we'll be open to answering questions or welcome any comments. So in summary, what we felt is obtaining health and genomic data is central to understanding the role of genetic factors in health and disease. This successful data sharing relies on public support, which in turn depends on willingness of people to donate their data, which can be shared for research. And then later on, this subsequently results in societal benefit and factors which across social, cultural, and legal context need to be addressed. Those who are familiar with genetics and DNA appear to be more likely to be willing to donate. In India, creating public awareness is essential for the success of projects involving genomic and medical data collection. And that is why urgent steps need to be taken to address this and provide this awareness. I would like to acknowledge Richard Min for helping us, Aruna Priya, Venkatesh, and Ghanshyam, as well as a horde of genetic counselors who participated in the focus discussions. Thank you.
Thank you so much, both. That was that was an incredible suite. You've done so much work around the study as well as the kind of analysis of the data. And I think, yeah, I mean, for me, kind of seeing that suite from the kind of health policy through to the kind of policy recommendations via ydys was brilliant. We do have quite a few questions in the Q&A as well, so we'll try and get through as many of those as we can. And Annie and Swam, are you happy if sorry, my screen's going a bit funny. Are you happy if we don't get through for people to contact you afterwards as well?
Yeah, sure. No issues. Do you want us to read the questions and answer them ourselves, or?
Yes, if you don't mind. I mean, yeah, I suppose that I.
Okay. So the first one is Brianna Cham. Do the beliefs of different religions result in differing willingness to donate? Perhaps some religions, I don't have any examples, may prohibit or discourage sharing certain types of information. Okay, Brianna, we did not divide the religious thing into any type of belief, but the major religions which we think we were talking about, none of them prohibit or discourage giving information or sharing of data. In fact, it is believed, I put it in quotes, that religious people should be more giving. All religious people give a holier than thou attitude, saying that we are the givers. So I don't think it's that, but I believe that the more liberal people are more willing to give. And that's what comes out, because even women, older women, younger women who have claimed that they are not religious, they are the maximum percentage showing donation.
So just to follow up on that, I think if you were going to ask more questions, do you think that somewhere about kind of political orientation, about kind of liberal versus conservative might be more, or you?
Yeah. The next question is from Deepa Bhatt. How does the law to protect the privacy and misuse of the information compare across countries? India being the country of cultural diversity and inbreeding, how additional care is taken to ensure the data is not misused?
Okay, I would like to answer that question. So there is no proper DNA Data Protection Act in India as of now. It's just a draft policy. And if I compare it with other countries, the EU has a law, but it does not specifically talk about DNA protection. So we currently do not have a proper policy that underlines all of the problems and how data is used, stored, or misused. Given India has chunk of diversity and it needs additional care to be taken. That is where when I was talking about how the public policy should be made, it should be an bottom-up approach so that every person is taken into consideration and all the aspects is taken into consideration and specialists are talked with, and then we come down to making a policy.
Can I just, can I just ask a follow-up on that? Because I was just interested, so, because India's federated, isn't it? It's a federation politically. And so how much, can you hear me?
Yeah, we can.
I was just interested in how much policy related to kind of things like data is made at state level and how much is national level? Is it?
Policies are mostly national. Implementation of the healthcare drivers is state. So we don't work on the federal mode. The policies and policy making is always at the national level, center. And then the states are, in the state portfolio comes health budget. So that's different. And that's why every state decides on which area of health they want to spend on. Some may decide on neonatology, some may decide on antenatal care, some may decide on non-communicable diseases, some on public health, like Kerala does. Kerala does on public center, center. Okay. So, did we answer your question, Richard?
Yes, thanks. I suppose I was trying to work out how centralized and how homogenous things would be if, and how much of discretion, I suppose, there is, but you answered. Thank you.
Yeah, Karthik has given a very big question, but the gist of it is that he believes that education and DNA donation, why are we connecting it? And it should be more related to awareness. And he's right. That's what we have been talking about. That was our whole presentation, was that awareness needs to be created. And we demonstrated it very well by the focused group discussion, where educated and aware and educated and unaware. So I think that has been taken care of by our presentation. Yeah, again, Karthik has written that when you use the word donation, that's why people think of it as organ donation. The word donation makes them think that, and that is why there's, so he's correct again. And that's what we did say, that they believed it. Many people believe that it was something to give. It's not a willingness to provide the information. So the word donate is giving them a connotation of organ donation. Okay. Lekhanda, what might be the relationship between people who have a case of genetic disorders in their family and their willingness to donate? Lekha, this has not come out in the survey, but we know very well that people and families who have an individual suffering, then we definitely see a greater willingness to donate. Okay, one more is, how do the panelists view a probable future when the concept of race collides with easily accessible DNA data? Yes, in fact, I think that if India doesn't contribute to the DNA data, we will be discriminated against, because we will not be in the healthcare system where we are looking at so-called pathogenic variants of unknown significance, all that, because that data we don't have. And we will not be able to give the correct advice correct formulation for healthcare. So I think rather than, that's why all the minority countries, minority groups would need to be more involved in donating the data. And in India, what I would like to say is, because we don't have a large government program like NHS, or now the Middle Eastern countries, they're doing sequencing of DNA data. But in India, a lot of our data is with companies, because patients are giving money to do the tests, they get a test report, but the remaining data is with the companies. So if that data could be put into a public platform, I think that would give us a lot of variance. But every company which does sequencing has a desire to keep that data, because then they can share it with for-profit companies. Anything, Richard?
I think you've done a fantastic job of answering all the questions. I just wanted to follow up on Kartik's question, actually, about, because it's one of those, I think when the survey was written and when we talk to people about DNA, that question of what you're asking them to do is quite interesting. And I suppose if you didn't use the term donate or donation, how else would you, maybe based on the discussion in your focus groups, what other language might you use around that?
Maybe give or share rather than donate, because donation in India, you know it, we have a large requirement for organ donation. And because of that, there's a lot of issues about, and we don't have that many cadaver donations. Then we had to change our policy a lot about family donations, emotional donations. You know, I don't know whether you're aware or not, but 80% of family donations of organs in India is from a wife to a husband. They're all spousal. And that is why we had to reframe the law and say that, you know, we don't want only so-called emotional as family, because that's an emotional relationship. It's not a family relationship. And so now the rule is that a wife cannot donate an organ like a kidney or something to the husband unless the disease was developed 3 years after they were, a minimum of 3 years after they were married. Because there was a lot of foul play going on where people would get married to get an organ and do it. So there, it is a lot of legal and illegal things for donation. And that's why maybe Kartik feels that the word donation may lead us into those factors.
That's really, really interesting. I think it's another example, I think, as we've translated the survey as well, the way that it's not just the kind of language translation, it's the meaning translation as well, and how, you know, what terms like donation mean different things in different settings. I think in the UK, it often gets very wrapped up with kind of blood donation and the National Blood Service, and this idea that you're kind of donating something to this greater good kind of thing. And it's, yeah, I think it does affect how people think about it. So
yeah, like blood donation also, let me tell you, Richard, in India till the 90s, we were giving monetary remuneration for blood donation. And then we made the word voluntary. You could not pay for it. And that caused a real reduction in our blood banks. So then we went on to do replacement donation. That means if my family member needs 5 units of blood, I should run around and find 5 volunteers to replace it.
wow.
And it's totally different. Like in New Zealand, when I was in New Zealand, everybody when they turned 18, they started donating blood, and they would fix a day in their life, you know, their mother's birthday or their father's death anniversary or something, and say that we are going to donate a unit of blood every year. So there's some things like that. In India, we have to have camps for donation. We have to have voluntary, because once the remuneration was removed, then voluntary donate. I mean, it was still called voluntary, but it had a remuneration. I remember in the 90s, there would be young people who would go and just donate blood and get money and come back.
I would love to keep talking because this is, and there are more questions coming in as well, I think. So we'll but we have run out of time now. So I just wanted to thank you again enormously on behalf of everybody who's attended today, I think, and particularly on behalf of us at Connecting Science. For everybody who's, and I think somebody said that they couldn't see the slides, all the slides and the recording will be available online afterwards, and we'll send out the links to that. And there will be another Your DNA, Your Say seminar coming up later in the spring, early summer, and keep an eye on our website or our mailing list, and we'll let you know about that. But yeah, again, Annie and Swayam, thank you so much. And
thank you so much for having us. Thank you. Bye-bye.